Hello, my name is Vecihi Batuman. I am the interim chair of the Deming Department of Medicine. I want to welcome you to today's weekly medicine grand rounds. Our speaker today is Dr. Cindy Leissinger. Dr. Leissinger received her medical degree from Tulane and completed her internal medicine residency at Tulane. She then completed a research fellowship in hematology at the National Institutes of Health and a clinical fellowship in hematology and medical oncology at Tulane. Dr. Leissinger is currently a professor of medicine and clinical professor of pediatrics and pathology at Tulane University. She's also the chief of the hematology oncology division, and she's the director of Louisiana Center for Bleeding and Clotting Disorders. Dr. Leissinger is a fellow of the American College of Physicians and a member of the American Society of Hematology and the International Society on Thrombosis and Hemostasis. She has been a member of the Hemophilia and Thrombosis Research Society since its inception and has served the society in numerous leadership positions. An expert on coagulation disorders, Dr. Leissinger oversees an active research program that receives funding from the National Institutes of Health and many other federal and industry sources. Under her direction, Tulane serves as one of the 16 member institutions in the NHLBI's Transfusion Medicine Hemostasis Clinical Trials Network. After her presentation, I'm expecting that there might be some time left for questions. So please type your questions in the section for questions, and I will try to read them to her for her to answer. I'm now very pleased to introduce Dr. Leissinger to you. Her topic is COVID-19 and venous thromboembolic disease. Thank you, Dr. Leissinger.
Thank you so much, Dr. Baudeman, and thanks to everybody who's joining us this afternoon. We're going to spend the next few minutes talking about this topic that's, I think, becoming a major problem, being recognized as a major problem in COVID, and that's the incidence of thrombosis. Here are my disclosures. I should mention that none of these are relevant to the topic that I'm discussing today, but I will discuss some off-label uses of some drugs. So, you know, when we think about clinical thrombosis, it's the tip of the iceberg because there's so much that's happening in the body that is sort of below the surface that we can't see. And this is certainly going to be true of patients with COVID, as we'll see as we talk about all of the thrombogenic factors that come into play in these patients, particularly as they become very ill with COVID. So our agenda is first to look at COVID-19 as a hypercoagulable state, and what does that mean? We're going to talk about preventing VTE in patients with COVID-19. We're going to talk about managing VTE in patients with COVID-19. And we're going to talk about managing patients on anticoagulation or those who have a previous history of clotting who present to the hospital with COVID-19. So these are all clinical scenarios, I think, that we find ourselves in very frequently now as this pandemic progresses. So the first thing is, you know, is COVID-19 itself a hypercoagulable condition? And I think that most everyone would agree that it is, because we know now from numerous reports, both anecdotal and now early publications coming out of both China and Europe, some early ones I think being submitted from the US, that VTE or venous thromboembolism in hospitalized COVID-19 patients ranges from 25 to 60%. And more importantly, we're seeing reports where it's actually even occurring in patients who are on some form of VTE prophylaxis. And we'll talk about that and maybe ways that we can optimize VTE prophylaxis. It does appear to occur at rates that exceed VTE rates in other severe critical infectious illnesses. I mean, certainly we know that VTE is definitely a risk in any patient who's in the intensive care unit on a ventilator with sepsis. But I think the general gestalt from the docs who are there and taking care of these patients is that they're seeing more than what would be expected even in those patients. Also remember that patients who have COVID also have laboratory evidence of activation of coagulation. So we're seeing things like elevated D-dimers, mild thrombocytopenia, even in some patients as they progress or disease worsens, prolonged prothrombin time, prolonged PTT. And then finally, there are a smattering of postmortem reports that have been published now with on patients who have had COVID that are reporting occlusion of small pulmonary vessels, thickened vessel walls, basically what looks to be a microvascular, widespread microvascular thromboses in lungs. Some have described it as microangiopathy limited to lungs. But with that, also findings on autopsy show that there can be pulmonary and alveolar hemorrhages. I bring this up as a counterpoint because later on, we're going to tackle the question of whether, because this is such a thrombogenic disorder in the lungs and the lungs are so affected, you know, there are some proponents of just anticoagulating, fully anticoagulating severely ill COVID patients, whether or not they have a clot, or even in those who don't have a clot. And I think it's important, you know, I bring this up here as a reminder that there are going to be side effects, right? So when we use anticoagulation, there are going to be potential side effects. So what are the factors that might contribute to hypercoagulability? I mean, I think we're just starting to, you know, kind of think about this first point, but it is clear that vascular endothelial cells do express ACE2, the angiotensin converting enzyme 2, which we know is a receptor for the SARS-CoV-2 virus to enter affected cells. So it seems pretty clear that the lining of the vasculature, the endovascular cells, can themselves be infected. Now, we don't know exactly what kind of disruption this causes, but we certainly know that, you know, clotting, that the free and smooth movement of blood through small vessels is important to prevent clotting, and that when sludging, not just sludging, but when there's disruption of the vascular endothelium, that is in and of itself a risk for clotting. We also know that symptomatic COVID-19 is clearly associated with underlying conditions, that severe cases of COVID-19 is quite typically seen in patients who have these other disorders, patients who are advanced age, who have obesity, smoking history, diabetes, cancer, and all of these things are in and of themselves risks for clotting. So now we're starting to pile up risk upon risk. And then we know that the severity of COVID-19 symptoms is going to lead, of course, to inevitable immobilization, certainly in the severe patients on ventilation or who are in the ICU for weeks on end. So clearly immobilization is another factor. And then we've got the issue that COVID-19 is clearly a hyperinflammatory state, and that we know from marked elevations in inflammatory markers in the blood. And we'll talk about those on this next slide. So what are some of these abnormal lab studies that have been highlighted now and are being routinely followed in patients with COVID? Well, we see increases in some of these various lab parameters, and they are associated with increases in disease progression and poor outcomes. And of course, one is LDH, and that could simply be tissue damage or tissue destruction. But when we think about CRP, when we think about ferritin, or interleukin-6 is another one that's been reported to be high in patients who are very sick with COVID, these are all markers of inflammation. And so is fibrinogen. So it's not surprising that we're seeing very high levels of the clotting protein fibrinogen. And fibrinogen, as you know, is itself an acute phase reactant. D-dimers are increased, and of course that is a critical piece of this, is what are the D-dimers are indicating that there's clotting that's being formed and broken down. What hasn't been measured, and I can almost guarantee would be high if they were measured, or things like factor 8, clotting factor 8, von Willebrand factor. These are clotting factors that are stored in endothelial cells that are very responsive to inflammation and are often very high in inflammatory states. So even though these are not routinely measured, nor am I recommending they be measured, but I think what we would find is not only does high fibrinogen indicate that there's hypercoagulability, but I'm sure that we would find very high levels of 8 and von Willebrand factor, fibronectin, and some other thrombophilic proteins. So inflammation is strongly linked to thrombosis, and hyperinflammatory states are in fact, hypercoagulable states. So just a word about D-dimers. As I think most everyone knows, they are the breakdown product of cross-linked fibrin. What that means is that this is specifically a marker for activation of clotting. So in order to have cross-linked fibrin, it means that the potent enzyme thrombin has been generated from the clotting, the typical clotting cascade that generates thrombin, and that thrombin converts fibrinogen to fibrin. And the final step in making a firm or good fibrin clot is the cross-linking of fibrin to itself by factor 13. In order to have D-dimers present, it means that all of these steps have happened. Fibrinogen has been converted to fibrin, fibrin has been cross-linked and stabilized, and so it is, again, just emphasizing that it is a highly specific marker of actual clotting that's occurring. So what about the clinical relevance of all of this? So starting very early on in the epidemic, there are a couple of studies that have already been published by Chinese investigators. The first one that I want to look at is the abnormal coagulation labs, and in this particular study, 183 consecutively admitted patients to a single hospital were compared for the outcomes, that is survivors versus those who died. And it was compared to the admission labs on each of those patients. So this data was collected in January, so very early on in the pandemic. Not surprisingly, what you can see is that those who did not survive, there were 21 who died, 162 who survived. The ones who died were older, and that was statistically significant difference. But importantly, you can see, and here's where I think the first inclination or the first indication of high D-dimers came about, is when you look at this group of the non-survivors, how much higher their median D-dimer was on admission to the hospital than those who survived. So the survivors had a D-dimer that was maybe slightly above a normal level, but those who died clearly came in already with a very high D-dimer. So a second study also out of China looked at very similar things, again, looking at abnormal coagulation labs on admission and how it compared in those who survived and those who didn't. And in this study, there were 191 consecutively admitted patients, 2 hospitals, and they were looking at these admission labs. So again, this was data collected very, very early on in the month of January and published online in March. And what you can see here is they measured not just the coagulation factors, but they also measured the inflammatory markers. And quite clearly, statistically significant are ferritin, which is much higher, and again, on admission, much higher in those who were destined to not survive, as was interleukin-6. On the other hand, when you look at the coagulation factors, those two were different on admission. And again, very similar to the previous study, D-dimers were just barely above abnormal in the survivors, but were quite high in the group of patients who died with COVID. So that's telling us a bit about how these coagulation markers relate to survival and not. What we now are awaiting are studies that will link these markers to actual thrombosis. And interestingly enough, while I know those studies are underway, we don't have any published yet. I mean, but I think it is still quite telling that we can look at coagulation markers and how it compares to the ultimate outcome, which is survival or death. What we do know, and there are some smaller studies that do look at the incidence of VTE in COVID-19 patients, and again, first reported from China. This was a prospective analysis of 81 severely admitted ill patients who were admitted to the ICU. And in this group, this early group, no prophylaxis was given to these patients. And over time, 25% of these patients were diagnosed with a lower extremity DVT. Not surprisingly, that DVT group was older, had higher D-dimers on admission, and also interestingly had, or maybe I should say not surprisingly, had a higher death rate as well. Again, another study that looked, it was now a retrospective analysis of outcomes in 184 consecutively admitted COVID patients. And this particular study was done in the Netherlands. Most of these patients had been given prophylactic anticoagulation. There was no standardized regimen. It was kind of a physician determined what the regimen was. And in retrospect, many of these were on a very low dose prophylactic regimen with a low molecular weight heparin that's available in Europe, not used here. But its equivalence would be a what we would consider very underdosed in terms of a standard low molecular weight heparin regimen. And in these patients, again, despite being on some prophylaxis, 31% had symptomatic VTE, and most of those, in fact, were PEs. And again, this study from France, a prospective study now of 26 consecutive patients who, and these patients were placed on ventilators. So these were, I guess you would say, the worst of the COVID patients. All were placed on some form of prophylactic anticoagulation at admission. Again, here the dose was determined by physician, and it was not all over the map, not consistent. And Doppler studies were done routinely on these patients. So this was a study, it was a prospective study. Doppler studies were done at or around the time of admission, and then they were repeated at 7 days if the initial Doppler study was negative. And so what was found is that a very significant portion of patients, 69%, had, again, on this monitoring on study of lower extremity Dopplers, over 2/3 of these patients had lower extremity clots. Now, in all fairness, about 1/3 of these clots were superficial, but a significant part of these, most of these clots were in fact deep, DVTs. And then of these, 6 of the 26 patients had symptomatic PE. So again, just evidence for this very, very high incidence of DVTs as well as PEs in these patients. So now, you know, the question is, and we've just talked about patients who are on some prophylaxis and still, you know, developed VTEs. What can we do better, or how can we prevent VTEs in COVID-19 patients? And so I'm going to start with the case to think about as we go through this section, but this is the case of a 72-year-old African-American gentleman who has a history of diabetes and hypertension. He presents with a history of worsening fever, chills, and cough. He's febrile. He's noted to be overweight with a BMI of 29. He is tested and is COVID-19 positive. He started on oxygen and he's admitted to the COVID-19 floor. His initial labs show a normal hemoglobin, a mild lymphopenia, which is also quite common in these patients, and a normal prothrombin time. His platelet count is slightly low at 110,000. D-dimers are high at 2.5. Fibrinogen is high at 650. So which of the following are we going to recommend? And our options are low molecular weight heparin, enoxaparin, 40 milligrams daily, apixaban, which is an oral DOAC or direct oral anticoagulant, 5 milligrams BID, that's a coagulation strength dose, unfractionated heparin, 5,000 units, prophylactic dose, or mechanical prophylaxis alone. So we'll think about that as we go through the next few slides, and we'll come back to this gentleman. So while we don't have any studies published yet on the efficacy of what we would call adequate prophylaxis on the incidence of VTE in COVID patients, we do interestingly have a study, again from China, of a large number of patients looking at the effect of prophylactic anticoagulation on survival. And this was a 28-day study looking at the 28-day mortality rate in almost 450 consecutively hospitalized patients with COVID-19 who all had high D-dimers at the time of admission. So interestingly, in this group, some of these patients almost a fifth of these patients received prophylaxis, and they actually received what we would consider here in the US adequate prophylaxis using enoxaparin, either in a 40 or 60 milligram daily dose for at least a week. So what they did was compared, as you can see on the bar graph, they looked at admission D-dimer levels and looked at the mortality rates in those who were on prophylactic anticoagulation in blue and those who were not on prophylactic anticoagulation in orange. And what you can see is a clear trend if the admission D-dimer levels were high, and here we start with more than 4 times the upper limit of normal, all the way up to more than 8 times the upper limit of normal, you can clearly see a trend in differences in survival with decreased, better survival rates in those who receive prophylaxis in blue. It becomes statistically significant in the high D-dimer, so greater than 6 times the upper limit of normal. That's roughly about a D-dimer of 3. Which is, you know, what we consider a high D-dimer. And you can see that as that D-dimer, admission D-dimer level was higher, so was the benefit from the good prophylactic doses of low molecular weight heparin. So what we really are left with as we wait for more studies on specifics about, you know, which particular regimen may be best, which particular prophylaxis regimen may be best. There is a very major growing consensus from coagulation specialists around the world that unfractionated heparin seems to be inferior, even when used in appropriate prophylactic dosing, seems to be inferior to low molecular weight heparin used in prophylaxis dosing. So what you'll see, I'm going to run through a couple of society guidelines that have been put out to help physicians make decisions on treating patients. So the first is the ISTH, or the International Society on Thrombosis and Hemostasis. Their guidance was recently published, and they recommend low molecular weight heparin prophylaxis should be considered in all hospitalized COVID-19 patients, including non-critically ill patients. And this should be done in the absence of any contraindications, obviously, any active bleeding or patients with very low platelet counts. And I should say that fortunately, of all of the abnormalities that seem to go with COVID, very low platelet counts does not seem to be one of them. Mild thrombocytopenia, but generally not very severe thrombocytopenia, except in very certain circumstances. So, and then ASH, the American Society of Hematology, and I do want to put a plug in. The ASH has a fabulous website that is curated, it is updated very regularly by specialists in the field, coagulation specialists, as well as it deals with other aspects of COVID and hematology. But I would refer anyone to that, to the website of the American Society of Hematology. They do give guidance on prophylaxis, and again, recommend that all hospitalized patients with COVID receive prophylaxis with either low molecular weight heparin or fondaparinux, unless there is that risk of bleeding. And they, of course, also make a strong statement that where patients cannot take anticoagulation or it's contraindicated, that there should be aggressive use of mechanical prophylaxis in those patients, recognizing the very high incidence of VTE in these patients. I show this slide. It is comes from the ISTH as well, and this is dealing somewhat with prophylaxis, but also deals with recommendations from the ISTH on measuring and monitoring, I suppose we'd say, the coagulation abnormalities that we talked about earlier. Starting with, you know, every patient presenting should have a D-dimer, prothrombin-time, platelet count, and fibrinogen. They consider that decreasing order of importance, with D-dimer being the most important. I think most of us would agree with that. And that in patients who have levels of these that are not markedly raised or abnormal, but if they get admitted to the hospital for other clinical reasons, coughing, fever, whatever, that of course they should be started on prophylaxis. On the other hand, if you have patients who have very abnormal coagulation markers, that even if they have no other COVID, major COVID concerns, that consideration should be given just based on these markers alone, that these patients be admitted for follow-up. And of course, that prophylaxis would be started in all of these admitted patients. But I thought that this was interesting, and I think it reflects what is going on in most hospitals, and that is that these coagulation parameters are now being looked at pretty routinely, I think, and monitored, whether it's daily. I don't know that twice a day is necessary, but certainly daily as these patients are in the hospital. So, having said that, what is optimal prophylaxis for these patients? So just at the outset, I'm going to say that I have had the opportunity to look at numerous guidelines from numerous facilities, places where there's a great deal of expertise in coagulation, and colleagues of mine at places such as the Cleveland Clinic and New York hospitals, hospitals in France, hospitals in Italy. What I can tell you is no two are alike. No two protocol recommendations are just alike. But there are some key features to all of them. And so what I'm going to try to do is summarize what I think are the important messages that come through on all of these varying hospital and ICU protocols for prophylaxis. Number one, low molecular weight heparin. And in the US, that is, typically going to be enoxaparin. That's what we have the most experience with. And that number two, that we not be afraid to measure anti-10A levels in patients to whom we are given prophylactic low molecular weight heparin, because we can target a goal between 0.2 and 0.6 units per ml. And if we do that, it kind of almost doesn't matter like what dose or whatever. It's that what we're doing is we're striving to keep patients in a good prophylactic range of anti-10A, which is how we monitor or measure low molecular weight heparin activity. So, of course, you have to consider bleeding risk and adjust accordingly. And then if there's renal impairment, and we have to take that into account. We might have to consider, if it's very severe, we might have to consider unfractionated heparin as opposed to low molecular weight heparin, since low molecular weight heparin is cleared by the kidneys. But we can make some adjustments for mild renal insufficiency. And then, of course, if there's high bleeding risk, obviously, we all, universally recommend as aggressive mechanical prophylaxis as possible. So I will just share with you what my general recommendations are, kind of based on those principles. So for hospitalized patients who are not critically ill, I recommend initiating standard dose prophylaxis with enoxaparin, 40 milligrams a day. That's a very standard dose used widely in the US. However, if the patient is obese, very obese, or with very high coagulation markers, fibrinogen greater than 800, D-dimer greater than 3, I would consider and recommend considering a higher dose of enoxaparin starting at 40 twice a day. If there's renal insufficiency, I would consider starting at a lower dose. But critical to all of this, wherever we start with these altered doses, is to check an anti-10A level after the third or fourth dose, and then adjust the dosing to get within the range that we feel is protective for these patients. So that's for not critically ill patients. Then for patients who are in the intensive care unit, for those who are on ventilators, for those who are critically ill, I recommend considering high dose prophylaxis, and that is the 40 milligrams twice a day. If the patient is markedly obese or has extremely high coagulation markers, as we've mentioned, we might want to consider even higher, 60 twice a day, although again, I don't do that lightly, and that is on a case-by-case basis. Obviously, if there's renal insufficiency, we're going to recommend a lower dose, depending on just how severely impaired the kidneys are. If they're severely impaired, then it has to be unfractionated heparin. Again, though, while we're using these non-standard prophylactic doses, we check an anti-10A level and we adjust. So whereas we might begin on a 40 twice a day, after 3 or 4 days, that dose may be reduced to a lesser dose or even potentially a higher dose. But the value, the great value is being able to look at the anti-10A level. So, okay. The question I told you that's coming up more and more, I've heard some physicians being interviewed in New York who talk about fully anticoagulating their patients, because I think, again, it's a desperate situation. Patients who get placed on ventilators have a very low likelihood likelihood of coming off. They have extensive lung disease. And some of these physicians have seen so much PEs and clotting in the lungs that some are discussing and actively placing these patients on full dose anticoagulation, even though there's no clinical evidence for an actual PE or clot. So so typically their guidelines will say something like, for patients with very high D dimers, greater than 3, fibrinogen greater than 800, on a case-by-case basis, we'll fully anticoagulate. Here is my recommendation, and I will tell you that I think there's at least some consensus among other coagulation specialists that I know and that I talk to. I think the general consensus, and I think the ASH website expresses this as well, the general consensus, I think from our point of view, is to reserve full anticoagulation for patients who clearly have an objectively proven VTE or PE, clearly they need full anticoagulation, and those patients in whom you have a very strong clinical suspicion for VTE or PE. And we'll talk about how we might do that evaluation in a few minutes. But we do not recommend a sort of a universal full anticoagulation in patients just because they are severely ill with COVID and ventilated. Just keep in mind, a very high D dimer, while it certainly speaks to the fact that there's clotting going on, clots being formed and clots being destroyed, it is not in and of itself an indicator or an indication for full dose anticoagulation. And again, remember we talked about those reports of alveolar hemorrhage. There's a downside to using more potent anticoagulation. So at this point in time, barring additional studies, and some studies are going on, and barring more information, we do not recommend full anticoagulation. The next question that comes up is, what about, when we do have patients who recover and are in the hospital and getting ready to go home, and they may have been in the hospital for 2-3 weeks, right, before they go home, what should we do about their prophylactic anticoagulation that they've been receiving during the hospitalization? So these are patients who haven't had a clot, who are doing well, going home. So I'll tell you, there's no real consensus on this. And again, looking at guidelines from various institutions and hospitals around the US, I see a wide variety of recommendations. I feel it's best judged on a case-by-case basis. I personally am not recommending that for someone who has recovered, who is likely to be up and moving around and they're feeling better and they go home, I don't have a standard recommendation for continuing prophylaxis, with the exception of patients who may have other underlying risk factors. So, in a patient who has cancer, or in someone who is going to be immobilized for a prolonged period of time when they go home, that's different. Then I think we need to talk about that. We need to discuss what additional prophylaxis we should use. The other thing I think that this reflects too, coming from some institutions, especially in New York, that have been, go back 2-3 weeks, these institutions were overwhelmed with patients. And quite frankly, they were discharging patients who were still fairly ill when they went home and still very likely to be very immobile, still having high inflammatory markers, et cetera. I mean, again, I think on a case-by-case basis, I would certainly consider sending a patient like that home on continued prophylaxis for 1 to 3 weeks or so until they get back on their feet and they fully recover. So again, I think you evaluate the situation, the clinical situation, and make a decision on that. But I don't have a blanket recommendation for continuing prophylaxis after discharge. So let's go back to the gentleman that we talked about earlier. So this is a man who's in his 70s. So he's older, he has diabetes, he has hypertension. He's a bit overweight, he's not obese. But on his admission labs, he has, what's somewhat concerning, a low platelet count, a high D dimer, a high fibrinogen. I mean, they may not approach the level of some of the critical levels that we're concerned about, but clearly he has markers of coagulation, of increased coagulation. So which of the following do we recommend? So for me, this is clearly a situation where this gentleman, I would recommend, he's not going into the unit, he's not going on a ventilator. I would recommend the standard dose prophylaxis with enoxaparin. I would not recommend a full dose DOAC like apixaban 5 milligrams. Again, we prefer enoxaparin over unfractionated heparin in those patients who can take it. And we certainly would not rely on just mechanical prophylaxis in someone who could be on adequate medical prophylaxis. Okay, so let's move on to managing VTE in patients who have COVID. So those who now develop clotting. Okay, and so we're gonna stick with the gentleman we just talked about. And on the second hospital day, while returning to his bed from the bathroom, he complains of acute chest discomfort and sudden worsening of dyspnea. Shortly afterwards, he has one episode of hemoptysis, producing a small amount of bloody sputum. He is able to be evaluated with imaging studies, and it is demonstrated that he has a PE with a small pulmonary infarction. And so now we're going to talk about moving from prophylaxis to treatment. And so which of the following do you recommend? And I have several options. And I will tell you that it may be more than one option, may be appropriate. But I think your options here are enoxaparin at a full anticoagulating dose, 1 mg per kg twice a day, unfractionated heparin infusion at a full anticoagulating dose with appropriate lab monitoring, or apixaban 10 milligrams BID, which is also a full anticoagulating dose of the oral DOAC. So we'll think about that. So I think, one of the big problems that I feel our colleagues are running into, I'm sure constantly, and that is the difficulty in these very, very sick patients in recognizing and diagnosing VTE and particularly PE. So again, these patients are critical and they have critical pulmonary symptoms to begin with, and are on ventilators and all that goes with that. So there's a great deal of difficulty. I mean, the patients are unstable. There's a concern for, trying to get imaging studies for, having a wider exposure of healthcare workers or others to COVID. So there's just a lot of difficulty in obtaining diagnostic studies on these patients. And so again, some of our societies have developed some guidance, and I think it's good, and I'm going to share some of that with you. One, the British guidance says to consider PE for any sudden drop in oxygenation or any sudden onset of respiratory distress or decreased blood pressure in patients who cannot otherwise have imaging done. This is a kind of a busy slide, but I really thought it was important, and I took this really quite almost word for word from the ASH website, and I refer anyone to it. I think it's very good, but I think they make very important points on assessing these critically ill patients for possible PE. That if a patient is intubated and again sudden clinical deterioration with laboratory findings consistent with PE, especially if there are some chest X-ray findings or markers of inflammation are stable or improving. In other words, their COVID is stable or improving, but yet they have a sudden deterioration in pulmonary symptoms or function, consider PE. Also, look for other clues. So some of these very significantly ill patients will have physical findings consistent with thrombosis, like thrombophlebitis or cyanosis, peripheral ischemia. Certainly a lot of them on dialysis will have thrombosis of the filters and the tubings and so forth. I think that's that's something to consider very strongly in thinking about these patients needing anticoagulation. And then patients with respiratory failure, very high D-dimers and fibrinogen levels, in whom you suspect a PE, because you have ruled out other causes like ARDS or fluid overload. So these are ways that we're left with that bedside assessment of patients with PE. A couple of things to keep in mind is that while you will almost not ever see a normal D-dimer in these patients that are so ill, if you do, it virtually rules out a PE or DVT, right? So, I mean, should there happen to be a normal D-dimer, then I think you can, with some confidence, look for other causes of pulmonary deterioration. On the other hand, if you have someone in the hospital in whom you have seen regularly increasing D-dimer levels on serial monitoring, that does not in and of itself mean that this is VTE or PE, because we know that also just goes along with progression of the COVID disease. So the D-dimers in this situation are not your friend. They're not going to be your particular friend in making a diagnosis, as we're so often used to using D-dimers as a way to diagnose DVTs. I think here we simply have to put them on the shelf. I mean, they can be somewhat supportive, but they cannot be used as a diagnostic tool. If the decision is made that this is likely a PE and the patient is empirically started on full anticoagulation, which I think we would all agree is the right thing to do, I think there's a temptation sometimes later on, if the patient stabilizes, they come off the ventilator, and then you run them through the CAT scan to see what you have, and there's no PE, and you think, oh, well, maybe I need to stop anticoagulation. We absolutely recommend against doing that, right? Because those PEs can dissipate. They can, after several days, there's no way to go back and know what was actually happening at the time you made the diagnosis. Stick with your diagnosis. If there's not a cause for concern about bleeding, leave that person on full anticoagulation. Don't retrospectively go back and change unless you have incontrovertible evidence that they didn't, which would be very unlikely to find. So what about the treatment options for anticoagulation? I mean, we've already talked about prophylaxis treatment options. Well, here, I mean, we made a point about prophylaxis where we prefer low molecular weight heparin. I think for full treatment anticoagulation, I don't know that we have any sense or any even anecdotal evidence that low molecular weight heparin is superior to unfractionated heparin. I think either or. There are some reasons why I might still prefer low molecular weight heparin, but others might prefer unfractionated. But I think the strong preference here is that the patient be treated with heparin, whether it's low molecular weight or unfractionated, and that by so doing you have that ability to monitor, to adjust. Again, now you can adjust your anti-10A to the full anticoagulant levels. And so that's what I think one of the things in these very sick patients, it's very handy to be able to do that. And so again, we recommend heparin. The patient, and then an oral anticoagulant, it may not be suitable. I mean, for the sickest patients, they simply can't take oral meds. But what about a DOAC? What about in a patient who is not so sick in the hospital, has a clot? What about giving them an oral DOAC? And some people say, well, that's great because I can minimize the exposure of the nurses to the patient. They just take a pill a couple times a day. If it's a apixaban, which I actually recommend over the others, but it's still a minimal exposure to the patient. The problem here is that you only want to use a DOAC if this is a very stable patient and you are truly convinced that they will not deteriorate at some point and require ICU care and ventilation. Because once that happens and they have to go on a heparin, you will not be able to monitor the anti-10A level because the DOAC leaves a lasting, about a 72-hour effect on anti-10A that will prevent you from being able to use that anti-10A to know where you are with your heparin. And so I recommend against using a DOAC, although, again, there may be certain circumstances where it seems desirable or whatever. I mean, but you just have to think about that, about what might happen, and you don't want to be caught in that problem where you can't adequately do an anti-10A level. Now, it's different when the patient gets ready to go home. So now they're better, they've had a clot, we need to treat them for a period of time, and we recommend 3 months of anticoagulation. This is a provoked clot, so for patients who fully recover, we consider this provoked and we recommend 3 months of anticoagulation. And when they're ready to go home and they're very stable, now's the time to consider putting them on an oral, a DOAC. Again, I prefer a apixaban, but I think this is the time to switch them to a DOAC. And again, we do 3 months of anticoagulation, and that's assuming that the patient does have a full return to normal mobility, et cetera, and they have no other prolonged health issues that you should mandate that they stay on anticoagulation. They should be evaluated by their doctor for sure about when to stop this anticoagulation, but the general recommendation here would be 3 months. So let's go back to our case, and this is our gentleman who quite suddenly on day 2 of hospitalization develops a proven PE. In his case, he was asymptomatic enough COVID-wise that he could have imaging studies done. And so in his case, it was clear that he had a PE. And my recommendation for him would be, again, either the enoxaparin or the unfractionated heparin. Again, for the reasons I just kind of enumerated about the oral drug, apixaban, because he's in the hospital, and yes, he appears stable at this point, but we don't know where he's going to go in the next few days. And so I would prefer not using a DOAC that could then interfere with our ability to measure heparin or low molecular weight heparin levels. So finally, we're going to talk about managing patients who have had a previous history of a clot or who are already on anticoagulation when they get COVID. And so how do we deal with those? And so we'll look at another case of a 55-year-old lady who has a past history of multiple DVTs. She's maintained on a low dose of apixaban at present and has been for years, but she's now admitted with fever, cough, dyspnea. She has no other underlying health issues. She weighs about 70 kilos. And she's positive for COVID, and her admission labs do show a D-dimer that's high and a fibrinogen that's high. So which of the following are we going to recommend? Just continue what she's on, her low dose of apixaban, convert to a prophylactic dose of enoxaparin, or convert to a full anticoagulating dose of enoxaparin. So let's think about that. So when we're managing patients who are on long-term anticoagulation, many of these patients will come to us because more and more patients are on DOACs, right? Oral anticoagulants. So again, I think here it's a case-by-case call. I think that if the patient is very, very stable, may only be in the hospital a couple days, and then you think they're going to go home and you want to just leave them on their DOAC, that's probably reasonable. But if you feel that there's any potential sign of progression of COVID, I would make the switch from the DOAC to one of the heparins. If a patient comes in on warfarin, I absolutely recommend converting them to heparin or low molecular weight heparin. There's just too much uncertainty, difficulty managing that warfarin, all the monitoring that goes with it. And again, not just for the patient and all that's going on with the patient, but exposures of the staff, et cetera, to all of this that's going on with warfarin. So we just recommend that for the time they're in the hospital, they be on a heparin. For patients kind of like this patient who are on a lower dose maintenance anticoagulant, I would consider increasing to full dose anticoagulation if they have very severe COVID symptoms, if they have very high hemostatic markers, like we see here, and that they have a low bleeding risk. Because I'm not convinced that in these patients who are at the highest risk of clotting, that giving them prophylactic or even low dose anticoagulant, low anticoagulant doses, that would be sufficient for them. And then again, we said, for any unstable patient, we go to one of the heparins for the ability to monitor. What about patients who have a past history of clotting, but don't take any anticoagulation and they get COVID, right? I think these patients have to be assessed on a case-by-case basis as to whether you're going to put them on a prophylactic dose of anticoagulation or a full anticoagulating dose. I will tell you, and I think this is, again, it's case-by-case. I think there's no real consensus here. I will tell you my opinion is someone who has a very strong thrombotic history and for whatever reason is not taking blood thinners or anticoagulants, I am likely to consider and recommend full dose anticoagulation. Or if they have a history of clotting and they have a known severe thrombophilic defect, or they have a history of clotting and they have a very strong family history of thrombosis, I would at least consider for these patients full anticoagulation. If on the other hand, and typically it might be a woman who's in her 50s and she said, I had a clot when I was pregnant 30 years ago. I've never been on anticoagulation since then, never had another clot. I might consider a prophylactic dose sufficient for that particular patient. So again, I think this is on really a case-by-case basis. And so finally, we'll end up back with our case of the 55-year-old lady who has had multiple DVTs, who is maintained on this low apixaban dose, who's now admitted with very high D-dimer, high fibrinogen. And what do I recommend for this patient? As we just went through, I would not continue with the low dose of apixaban. I would not put her on prophylactic doses of enoxaparin. I would convert her to full anticoagulating dose of enoxaparin because of the features of her case. So with that, I'll wrap things up and just say a few things that COVID-19 is certainly associated with a very high risk for VTE. Mounting experience and much anecdotal evidence, it strongly suggests that standard prophylaxis with unfractionated heparin is not as effective as prophylaxis with low molecular weight heparin. So we do recommend, again, the low molecular weight heparin for routine prophylaxis. And again, you can, make a protocol of these various permutations of it and where we might go higher or a little bit lower. But the thing is, it all should be, when you do make a recommendation for something that's not the standard prophylaxis dose, those patients, you should check their anti-10A levels and then adjust accordingly. So that's an advantage of being able to measure anti-10A. I do think you have to maintain a very high level of suspicion for PE and DVT, even in patients who are on adequate prophylaxis. I mean, I think we've seen proven that these patients are still at risk for clots, and that when we treat with full dose anticoagulation, and we typically do with either of the heparins, low molecular weight or unfractionated, and that they can be converted to an oral agent when they go home. Even warfarin, I mean, can be, anyone who's on warfarin to begin with should certainly be converted back to warfarin, but in general, go on an oral anticoagulant for 3 months after hospital discharge. And with that, I have come to the end, and I think we have Dr. Baudeman a few minutes maybe.
Yes,
for
we
questions.
do. Thank you very much for this wonderful practical presentation. I'll start. There is a comment from the participants. Dr. Lasky wants to point out that they have an FDA-approved study in COVID patients using disulfated heparin with strong anti-inflammatory activity and lesser anticoagulant activity than normal heparin. The mechanism evidently involves inhibition of HMGB1 mediated inflammation and formation of thrombogenic neutrophil extracellular traps, also known as NETs. The study will start in May at Tulane, and Tulane is the lead study site. Then there's a question from Dr. Murphy-Lavoie. Should all COVID patients with an elevated D-dimer get a CT-PE study? Is there a different cutoff of threshold of doing this? Should all COVID patients get a D-dimer even if not hypoxic? In other words, discharge patients.
Okay, so let me see if I can remember and kind of unspool that. But one thing I want to say about Dr. Lasky's comment, one thing I didn't mention and should have is whenever there's an opportunity to put any of these patients on a clinical trial, that would be golden, because what we lack, as you can see as we go through what data is available, is while we have retrospective study and even some nice prospective looks at patients, what we don't have are randomized clinical trials. And if there's any opportunity to do that, and I just wholeheartedly support Dr. Lasky and his trial. But going on to talk about kind of what we do or how we manage this, and let me make sure I've got this. I think one question was about just the D-dimer monitoring. I mean, we absolutely do recommend that patients who are admitted with COVID do have admission coagulation parameters done that include D-dimer, PT, platelet count, and fibrinogen, and that those can be monitored, not only as risk for clotting, but also risk for progression of COVID. The question though about just on the basis, as I understand it, the question was on the basis of increasing or very increased D-dimer levels alone, is that cause enough to do a CT scan to look for PE? I will tell you that the consensus from most of the colleagues I have, and this gets talked about, is that no, at this point in time, that is not a general recommendation. That if it's only based on the laboratory D-dimer elevation, and there's no symptoms or there's no deterioration or there's nothing clinically that speaks to there being a PE, that that we in general don't recommend just doing routine imaging. I hope I got that right. I mean, I hope I got the question correct. If there's another follow-up to it, I'm glad to hear that.
Okay. Another participant is asking, in the past week, there have been reports of COVID toes, purple discoloration of toes, similar to pernio in asymptomatic children who had viral illness. This discoloration suspected or thought to possibly be a link to COVID and due to inflammation and microclots. Have any patients in NOLA had this clinical manifestation that you know of?
I truly don't know. I have read the same things. I mean, it's interesting that this seems to be more of a pediatric, and I really would welcome a comment from any of our physicians who are actively treating or treated a lot of COVID adult patients. Where I've seen it reported is in children. I do not know the mechanism. I mean, it's certainly tempting to hypothesize that this would have something to do with vascular insufficiency or vascular, even, you know, microvascular clotting, but I don't know, and I think it's very interesting, and also very interesting that it happens in children, who, by the way, pediatric children have a very low, as you know, very low likelihood of clotting, even in the face of very strong thrombogenic stimuli. Children quite often don't clot. So, so we don't expect to see a lot of clots. I mean, they certainly can, but we don't expect to see a lot of clots in kids. So this is very interesting, and I'm sorry, I don't know the etiology of it.
Okay. I think you partially answered this, actually, Dr. Cummings, regarding outpatient initial assessment of COVID patients. Is there value in checking D-dimers to help risk assessment?
Apologize for that. So I think her question was, is there value to checking a D-dimer if you're just evaluating for COVID?
Yes, for risk assessment.
Yes, I mean, we do recommend that if you have a patient who you strongly suspect with COVID or who has proven COVID, that absolutely that's, you know, one of the presenting labs that's recommended, the D-dimer along with the you know, a platelet count, a prothrombin time, and a fibrinogen, and that those can be followed and followed along. And even some people will point out, it's even if you send the patient home, it's good to have those labs as a baseline in case the patient comes back into the emergency room or back into your clinic with worsened symptoms, you know, 4 or 5 days later, to have that as a baseline.
Okay, another participant is asking, any suggestions for VTE considerations in outpatient management of COVID-19? What about in high risk categories for VTE output?
I'm sorry, I'm not sure I quite understand. I think the question is about outpatients, and
Right.
and perhaps the question here is, should you have a high index of suspicion for DVT? I mean, I think you should. I think just because of the nature of COVID, especially with these high procoagulant activities that we see when you do blood work. I mean, I would think, now there's no study. I can't tell you that I've seen a study of mild patients because we haven't seen those labs done in patients who are milder or who are managed as outpatients. So it's a little hard to make a categorical recommendation about what to do in those patients. So I'm sorry, I'm not sure that I know, but I would have a very high index of suspicion. So if the patient develops symptoms that speak to a possible DVT or PE, I would certainly image them. I'd certainly try to diagnose that.
Okay, this question is from Dr. Nakul. Any data on clotting risk in young COVID patients that may not be even hospitalized? Media reports seem to indicate prevalence specifically in younger patients.
I've read those media reports, particularly actually of strokes, of cerebrovascular thromboses, and again, I'm looking for more data, more reports of that, but I've read the media reports, and I don't know if it's just because it's more of a news story when it happens in someone who's 30 years old or 25 years old, but certainly that is happening. I mean, there are, and again, this is sheer speculation, but I mean, there are, certainly young women who are on hormonal therapies. I mean, we know there's some increased risk of arterial clotting with that. So I don't know. It would be very interesting to see who are the patients who are these younger patients who are developing these stroke-like symptoms, or even heart attacks, I think, have been reported too.
I think we're approaching the end of our allotted time, but the one last question is from Dr. Eldar. COVID patients have a higher incidence of acute kidney injury. Is there a high incidence of bilateral renal vein thrombosis in these patients?
I have not read. I have not read of any reports, anecdotal or otherwise, of specifically that. It's a good question, and one would think we might need to, and especially to the nephrologist in the group, is to maybe think about it and be aware that these patients, we know they have the risk for clotting. So it may be something that has yet been unrecognized, but is there.
And one last comment from Dr. Mushat is Mount Sinai just reported case series of large vessel ischemic stroke in adults younger than 50 years old. I'm afraid this brings us to the end of our time. I want to thank Dr. Leissinger for this wonderful presentation and all the participants online for joining us for today's Grand Round. Thank you all and goodbye.
Thank you very much. Bye-bye.